Thank you very much for that nice introduction. Actually, after preparing the talk, I thought the title should have been a bit different, so I changed it. So my new title is actually, like what I want to provide to you today, I hope you're still up to it, is how can we get a more precise, a more realistic account of people's health behaviors, health behavior change, and also the experiences, the situations, the feelings that come with it. And I think this will help you, or I want to help you or convince you why using ambulatory assessment methods might help you achieve these research goals. But before I get into why, I thought I'd just give you a short introduction to what is ambulatory assessment. So basically, I'll give you 4 signals. So one is self-report data. So it's experience sampling or ecological momentary assessment. Experience sampling is very old. I'll come to this in a second. It's normally paper and pencil. Ecological momentary assessment is more related, like the term is more often used for electronic data. And very often this is repeated diary entry. Ambulatory assessment is also, and I think this is some things that Antonio will do and know how, is physiological measurement. So you have accelerometry, but you also have pulse, you have glucose, whatever other aspects you want. And you have acquisition of ambient environmental parameters. I think the most well-known example is the ear, the electronically activated recorder. So you can assume that you have like a little device with you that at random times throughout the day will, for example, sample 50 or 60 seconds of what's heard around you. So basically it gives an idea of the environment, your conversations, your mood. For example, you do this if people have difficulties reflecting on certain issues. For example, in clinical research, you have someone in a bipolar episode, for example, you get an idea what their mood is like, how many interactions they have, these things, that's what it can be used for. So this is basically, ambulatory assessment is the umbrella term for this. I think what is important to know about ambulatory assessment, or what I want you to keep in mind during the presentation, is that it's a process method, so you want to get at what's happening at this moment or has happened very recently. Normally, most people who want to use it, second, is that they use repeated measurements, and this is, I think, where you also get in this. There's a wealth of data that you have the pleasure to deal with. So they have these repeated measurements. It is ecologically valid. So normally you try to assess things in the normal environment. So you don't go to the lab. You don't create an artificial control setting, but you go to where the people are, so you go out with them. So I think these are 3 important things to keep in mind. And I'll talk about why this is so interesting and how this can help you answer certain questions throughout the talk. I wanted to give you a small historical overview to give you an understanding how old this method is. And I think we've seen Darwin 3 times now. I'm like, wow. Like I wanted to talk about him in a different way, because he was the one who kept a diary of his child's life and used this to investigate emotional expression. I think this is maybe one of the aspects of his work that is less known. Münsterberg then in 1892, he kept a daily diary for 9 months to record mental and affective state 5 times a day, including behavior on 20 experimental tasks. For example, one of these tasks that he did, he used his fingers to estimate a certain length. And what he found when he analyzed the diary was that on days in which he had more positive affect, he overestimated the length that he would try to measure with his fingers. And on days with higher negative affect, he would underestimate this length. So he was like one of the first who tried to basically get into this moment, what is going on together, and try to put these things together and find these effects that you wouldn't probably find in the lab. And then Flügel in 1925, he did the first experience sampling study in this sense. He kept a diary and he rated his emotions on pleasurable and unpleasurable, also various times a day. And he was one of the first ones to find that he had more pleasurable events than unpleasurable events. And this is also a very important finding that we have today. Then, of course, there's Piaget, which, you know, I mean, the foundation of his stage theory is actually that he observed his children and recorded it in the moment into a diary. Later in 1943, there was Egon Brunswick. He was the one who coined the term ecological validity. And he, maybe you know him for the lens model, but basically he was the one who really pushed that keeping the environment in mind and the effects of the environment is super important, and that research should try to grasp this as well as it can. And then the last person I want to introduce you is Csikszentmihalyi. He was the first who used actually pagers to make random stimulus or random beeps to record a behavior. And I also just, because this is a very, and I think you've seen this in the previous two presentations, that's a very technological topic. Just wanted to keep you up track with the technological development during this time. So basically, when Csikszentmihalyi did this research, the pager was the cutting-edge tool, whereas later on the PDA came, then of course the internet, and now we're talking smartphones, iPhones, other things. And I think I have this. So what I promised you is that I give you 4 good reasons, that's what I'll do, why I think ambulatory assessment might be important for you or might allow you to learn more about your disease or answer your questions better than you could before. The first one is that ambulatory assessment avoids the over-reliance on retrospection. And this is today one of the most cited reasons to use it. For example, even Thompson in the 1930s, he wanted to test a Freudian theory that you remember unpleasant events less well than pleasant events. So what he did, he kept a diary for 5 days, then asked participants 2 weeks later about the events that they had experienced during this period. And he found that basically they remembered about 1/3 of the pleasant events and 1/3 of the unpleasant events. But you already realized they already forgot 2/3, right, after 2 weeks. After 6 weeks, they only remembered 1/4 of the pleasant event, but only 1/6 of the unpleasant event. So here again, this is a finding that has been replicated very often, that basically most people that don't have a mood disorder, for example, they remember pleasant events better. But I think another important message is that retrospection is not necessarily a good account of what actually happens. And this is a very often shown finding. My colleague Andrew Gloucester and I, we tried to take this one step further and used actually a task that physicians and other healthcare professionals, I think, use all the time. The question about, okay, let's say you're in pain. If you sleep better, is the pain less worse? Or you didn't feel so good when you exercise. Does that help your mood? So very often we ask about relations. How do things relate to each other? And so we asked exactly this question. We asked it to first-year university students who we had tracked for a year on their affect, on health behaviors, on stress. And then we asked them to estimate the correlation between certain behaviors. In that sense, in this case, physical activity, sleep, positive affect, and stress. And we asked them to estimate it for the week that has just passed, for the last week, and we also asked it for the last year, basically. And what I'll show you is the following. Here you can see the correlation between physical activity and positive affect. This is if you calculate it based on the ecological momentary assessment data, and this is what they reported they thought this correlation is. What you can see, I think, in general is, the match is not very good. Basically, if you analyze it statistically, you find like maybe one association that you would say, okay, here they're not totally off. I think this is the first important finding. So this very basic question that you probably talk about every day or healthcare professionals use every day, they were unable to answer this. The other thing I think is interesting about these results that you will see that the IMA-based correlations are relatively small. So this is another thing. So where we think there might be correlations in day-to-day, maybe they are smaller than we think, or they're also often called illusory correlations. The second point, I already talked about it when I talked about Brunswick, is the ecological validity of using ambulatory assessment. So you're there in the actual situation. So one question that is often done is whether findings from the lab can be actually replicated in such a natural context. Many of them can, many cannot. Some things I think that are also important, some studies you couldn't even do in a lab. And one of these studies I wanted to show you. It's a study where we worked with people who were acutely depressed and a control group of healthy participants who had never had any psychological disorder, which is in a way another extreme group. But anyway, we asked them for 7 days, 8 times a day, so a total of 56 times, how they were feeling that day, and we also asked whether in the last, normally it was around a 90-minute interval, but it was randomized a bit, whether they've been physically active. And one thing that we found was that if these participants were active, they also reported a higher positive affect than if they were not active. The interesting thing about this finding is, and why this is ultimately cited and used a lot in therapy, is we did not intervene on them. It was just their self-report, and we asked them for bouts that took at least 5 minutes, but they could be of mild activity. So basically, in contrast to previous studies who had looked mostly at physical activity intervention, so say, okay, go to the lab 3 times a week, you exercise for an hour, what is the effect? We said, well, this is quite a high standard, or that's quite a high behavioral goal for someone who's acutely depressed, to say, okay, now exercise 3 times a week. And we could show with this method that if you manage in your day-to-day life to include little bouts of activity, you will actually find correlations with higher positive affect. The third point why I think this is a rich way and might help you answer things is intra-individual variability. And I'm staying here with Robert, who always has 3 points for everything. I have 3 underpoints for this third point. The first factor I think is interesting about inter-individual variability is time. So in the study that I just described to you, we also looked at whether there were any differences between the times that participants reported being physically active and those that they didn't. So what you see here is at T, participants reported that there were, let me start this again, this is more complex. Okay, this is time point T, and this is time point T plus 1, right? So this is the next beep. And what you see here, the dotted lines, is when they had reported being physically active at T plus 1, but they hadn't been physically active at T. The straight line, the continuous line, is when they reported not being physically active at T or at T plus 1. So what you see is actually exactly what you would expect if you would think that physical activity is related to an increase in positive affect, because if you haven't been physically active between T and T plus 1, you don't see any difference in positive affect. But if you have started to become active at T plus 1, you see an increase. What I think is very interesting about this, if you think about effect size, is that if you're active, and again, you only need to be 5 minutes active, then you reach a positive affect that is not significantly different from those of healthy controls if you're in MDD. So I think that's quite an interesting result. You can also go further about this question of time like Marieke Wiechers did. So she looked at the question, how does positive affect develop over time if there's physical activity in the middle? So it's more the egg and the hen problem. So what comes first? Do I look forward to exercising and this is when positive affect increases, or am I physically active and then my positive affect increases? And here again, using experience sampling methods, she was able to disseminate this. So you can see that basically there's a relatively stable positive affect until the persons were physically active, and then she could show that this lasted around 2 or 3 hours. So this is something else you can do with experience sampling. Or in general, with repeated measurements that basically allow you to grasp these relations over time. I think another interesting point, or that is interesting to think about this inter-individual variability, is the difference between and within person level. And let me walk you through this, because it takes a moment to think about it. Basically, what we did here, we again worked, this is actually a pilot study of university students that we asked 32 times to tell us about their health behaviors, their affect, and their learning performance and their learning goals. And this is at the time of their final exams. And in Switzerland, at the University of Basel, these students were in the first year. If they didn't pass these exams, they could never study psychology anywhere in Switzerland again. So these people were under high pressure. What we then looked at, whether being physically active or sleeping better would affect their learning performance here, and whether this was mediated by the affective experience. And this is the between-person level. And of course, we then looked at whether meeting the daily learning goal achievement would also predict the examination success, so whether they would really pass these exams. And on a within-person level, of course, we could not look at this because this is only measured once, right? So you cannot have repeated measures per person. What is interesting about this is that if you think about the between-person level, you would think people who in general are more physically active, do they also have a higher learning goal achievement? And do they also report differences in affect? And we find, yes, they do, but only for positive affect. So we can say that people who are physically active, they experience higher positive affect, which then is related to a better learning goal achievement, to achieving their own learning goals, and that this predicts actually whether they will pass these exams. On a within-person level, we could show that on days on which participants were more active than usual, so again, they are their own comparison standard, that they had higher positive affect and lower negative affect, and that this affected their learning goal achievement. So here, it's a small difference, but there's a difference on the within-person level, so we would have not learned about the negative affect as mediator if we had only looked at the between-person level, and there's something that this doesn't tell us. And then I think the last point, which I think is particularly interesting and fun, and I think it's an important foundation for designing interventions, it's using the person as their own comparison standard. So again, just to give you the design of the study, so this is the full-blown study. We had 60 measurement points over an entire year. We combined a self-report with many other data. But basically, what we could show is that only looking at within-person differences, that comparing whether do I have a good day or do I have a bad day? Do I sleep better today? Am I more physically active than usual? Or do I eat less sweet or salty snacks? This all influences, for example, my positive affect, but it also influences your negative affect and learning goal achievement. So basically what we could show, without controlling for factors such as sex or general fitness level or weight or anything, we can show that for a person, if they change their usual behavior little or just a little bit, that we already have a difference in this case, the affective experience and their learning goal achievement. Does that make sense? So basically all these problems that you normally have, that you have tried to make these people comparable, so you know what you're comparing, you're not comparing apples to pears, you don't have to do anymore because you're comparing the person to herself. So in a way, I think if you understand this, and this is I think what's also interesting for interventions, you're not, I mean, in a way, you want to know if this person changes this, or if she or she does this, does that change the other thing that I'm looking for, right? It's not so much do men do more of this or women do more, but can this person do it? And I think this is something that this allows you to do, and you get rid of a lot of confounding factors. And the fourth point, and I think this, I mean, you have illustrated this better than I probably could have done it. I mean, the future, what has happened in the last decade, is that the ambulatory device is used as an intervention itself. So, and I think this is a good time to do this because now the subscription, for example, to mobile cellular phones are very high. And you see Portugal is dark red, which means that they have up to 304 subscriptions per 100 people. So, I mean, everybody has at least one smartphone or at least one phone. The Apple Store alone offers 13,000 health-related apps. I mean, talking about attention and like trying to get attention here. And there are estimates that alone in 2012, and again, this is 3 years old, 44 million of these health-related apps were actually downloaded. So, I mean, there's a huge potential going on there. What I found helpful when thinking about this, I mean, there are many different kinds of ways to intervene with ambulatory devices, is this taxonomy by Oller and Chimsky. So basically, they looked at medical use cases. But they said, okay, what do I want to use this device for? So is it a point of care for diagnostic? For example, do I want to know something like blood pressure over a longer time so I can tell whether someone has high or low blood pressure in general? Is it patient monitoring? So if you're talking about glucose, for example, or again, we could do blood pressure. Is it more wellness? I want to feel better, smooth things. Is it about compliance? So I can check, for example, again, in diabetes, how often somebody has entered and when they entered their glucose levels. Is it more about education? Is it behavior modification? That's what Antonio and Robert presented. Is it about efficiency and productivity, for example, in a physician's office where you can do some of these processes on a smartphone? Or is it about environmental monitoring? So this could be you have a GPS device which knows where you are and then tells you the UV level of UV rays, so you know you should use sun protection or not. And then once you decide where you are, you can think about, okay, what kind of device type do I have, what kind of interface, what do I have to use, and then what else do I have to consider in terms of regulation, in terms of security? And I think I'll get to this in a bit, but I think this is a very important and interesting point. And also of data management, because as you probably assumed, I mean, the amount of data you get is just enormous. I mean, you can just drown in data if you don't know how to manage and work on them. And I just wanted to give you an example. This has just been launched, the iHealth site. So basically what Apple is doing now, they offer you a dashboard where you can monitor up to 15 vital data that you always have available. And the thing that scared me a bit, I don't know how you feel about it, is that it can automatically share readings from these devices with a new health app, which basically with your doctors, with your health providers, your health insurance, so everybody is always informed about your health. And of course, this is stored in a cloud. So if you think about hacking, I don't know how secure it is, so I think this brings up a totally new ethical question, not only about data security, but also if you don't do it, do you get in a new risk category in your health insurance because they don't have access to your health board? I mean, so I think it brings a lot of new questions. Where do we want to go? What are the opportunities, but also what are the limitations? And I just wanted to give very quick wrap up of this in terms of what this decade of research with mHealth, as it's called, mobile health, has done. So some research suggests that it's well accepted to use apps for health behavior change, but in psychopathology, for example, this is less the case. So many people want different kind of care, and you find very low compliance rates. Some, for example, I've also found it for weight loss, show better adherence and retention in treatment. And a lot of research, that's not a surprise, reports achieving behavior change or health goals, but it's so young, as Robert also said, so it's very difficult to have a good sense of what's going on or whether this is publication bias. I think things that should really be considered is usability and acceptance issues. So who are we talking to? How can this be used? What is the age group? What is the patient group or like the client group? Then quality standards and safety. And that's about many of the apps that are developed are not theory-based or not empirically based. It's not totally clear what they do. And even if there's an app that has been empirically tested, very often it has not been tested as an app, but what has been tested is the program before. So we know very little about how these apps work. So I think the research you're doing is really important. And then the issue I already touched upon with the iHealth is data security and privacy. I think is a huge issue. How do you store these data and how do you make sure they're safe also for those people you work with? I wanted to give you a little, so these are the 4 points. So if you, I know I wanted to take 3, but I got 4 at the end. So, but if you can, these are the 4 points that I would hope you remember tomorrow, maybe. The last point, or the next question I think is very different when thinking about this kind of data, like how do you analyze it? And there's one gold standard that is often used, and I think that makes a lot of sense, is to use multi-level modeling. So basically you can assume that here you have dependent data. So you have data nested with another data. So you have a person and you have various assessment per person. So these data are not independent of each other, right? So if you use a normal type of analysis, you would assume that these are independent assessments, but they're not, so you misestimate the standard errors and other coefficients. So what you try to do is you basically use multi-level modeling, which is an extension of a regression model, and then represent in this model these nested levels. And just to show you that it looks like a normal regression model, this is exactly what you do. You just have you model behavior on a beep level, for example, and then you model the person level, and you can model as many levels as you like. So what did I want you to take home? It's exactly these 4 points that I talked about. Think about how ambulatory assessment can help you reduce effects of retrospection, increase ecological validity. Think about the potential of inter-individual variability. I think there's a very high potential. So in terms of time, in terms of comparing within and between person level and using the person as their own comparison standard. And of course, and this I think you've seen here, is that ambulatory assessment is used and is very interesting as an assessment intervention method. Thank you very much.